It's being called the most sweeping change in the history of healthcare in the U.S., the Patient Protection and Affordable Care Act, Obamacare. This is a live town hall meeting on the Affordable Care Act. Should Utah expand Medicaid coverage to the uninsured? Presented by Arch's Health Plan, the way healthcare gets better. And by Fringe Benefit Analysts, simplifying the Affordable Care Act for you and your family. Now, the host of tonight's live town hall meeting, Rod Arquette.
All right, and good evening, everybody, and welcome to our final town hall meeting tonight. This is the third in a series of 3 meetings that we've had on the impact of the Affordable Care Act here on the people of Utah, and it's great to be with you again tonight. We want to invite you as well and remind you that if you aren't here in our studio tonight, certainly you can be a part of the program. If you have a question, you can call us at 888-570-8010. You can text us at 59570 or email us at rod@knrs.com. And we've got a great program tonight. As was mentioned, prior to this, we've explored the impact of Obamacare on the individual and the family. Our second town hall meeting that we held last month, we talked about the impact on small business. Tonight, we're going to focus on a real issue here in the state of Utah, and we're talking about the expansion of Medicaid. Before we begin, I want to thank people for showing up tonight. We want to thank folks with Rodizio Grill for providing some food. Did you guys get something to eat? All shaking your head? Good. Glad you did. And we really want to thank our sponsors as well, Arch's Health and Fringe Benefit Analysts, for providing support. They've also provided panelists to the event in the past, so we really, really do appreciate it. Now, before we get underway, we have a great panel of people here tonight, experts on this issue, who can really talk about health care. They've been a part of this process and discussion of the expansion of Medicaid, and let me introduce them to you. To my right, you're right on the radio as well if you want to look at it right now, is State Representative Jim Dunnigan. Representative Dunnigan headed up the governor's task force to examine health care and to present him some options. Representative, great to have you back with us tonight. You were the first time you were here for our meeting. We appreciate you having you back.
Glad to be here. Thank you.
All right. Also, to my immediate left, and the left on your radio, is Riley Curtis. She is with the Utah Health Policy. She is their Medicaid specialist. Riley, how are you? And welcome to the show. Thanks for being here.
I'm well, thank you.
All right. And also joining us tonight, to my right again, is David Entwistle. David is the CEO of the University of Utah Hospitals and Clinics, also CEO of the Utah Hospitals Association. David, welcome.
Rod, great to be with you, and thanks for the invite.
And you were mentioning, David, that you've been in Madison, Wisconsin during cold winter months, so this is kind of like Florida to you, right?
I have been. This is a little balmy for me.
A little balmy for you. Well, great. And Derek Monson, the Senior Policy Analyst with the Utah-based Sutherland Institute. Derek, great to have you on, and thanks for being with us tonight as well.
Yeah, thank you, Rod. Glad to be.
All right. Well, as I mentioned, you can participate. You can give us a call, 888-570-8010. You can text us at 59570 or email us at rod@knrs.com if you have any questions tonight. Before we begin tonight and the discussion and the questions that you have, let me kind of give you some basic Medicaid facts. It was created in 1965, basically to provide health insurance to America's poorest and children. It is managed jointly by the federal government and the states, and it is also America's third largest government program behind Social Security and Medicare. Almost 8 cents of every federal dollar goes to pay for Medicaid in this country, and that amounts to about $265 billion a year. Just in federal expenses alone. State governments pay another $160 billion for Medicaid, and for some states, it's their largest single government cost. I'm not sure if that's the case in Utah. I think we'll certainly find out. Now, recent studies have shown that Utah stands to lose about $750 million by opting out of Medicaid expansion if we do. And there are studies that also show that expanding Medicaid could assist an estimated 125,000 Utahns, generate about $2.8 billion in economic impact, and create about 3,000 jobs. So as you can tell, there are a lot of pros and cons to expansion of Medicaid here in the state. As we begin tonight, I'd like to turn some time over to each of our panelists tonight and just kind of get their initial thoughts on expansion of Medicaid, where they think we should go, where the state may go with this, and all the pros and cons about this. And let's begin with State Representative Jim Dunnigan, because I know you have been deeply involved in this, Representative. Your general thoughts on expansion of Medicaid here in the state?
It's an extremely big decision for the state for many reasons. Currently, Medicaid takes almost 1/5 of the state's budget, so that's a big chunk. When I started in the legislature about 10 years ago, it took 1/10 of the state budget. And so we've increased that quite a bit. On the other hand, there are a number of people that don't have access to medical care. And so those are the tough decisions. Can we afford it? The federal government has offered to pay much of the expense of expanding it. Do we believe or trust that the federal government will be able to live up to that commitment when they're $16 trillion in debt and counting? And if they don't, then will the states be on the hook, and will we be able to afford it?
And is that your number one writing issue, of course, is the cost and how much Utah may have to bear?
Certainly cost is a big factor, and I don't want it to come across like I'm less than human and not sympathetic with those that need medical care. I have family members that would be benefited by Medicaid expansion. But we don't want to start a program that we can't maintain. I don't think we serve people well if we start a program and find out partway into it that the federal government no longer can live up to their end of the bargain. And then what do? We've already had a couple examples with the Obamacare that have ended up that way. So I think we have to be careful.
All right. Let me turn over to Riley Curtis. Riley, your thoughts on Medicaid expansion? I know your organization has been actively involved in this. What are your thoughts on where Utah should go?
You know, Utah Health Policy Project, because we are a nonpartisan organization, we try really hard to be at the table with, over the summer we were doing the governor's work groups. We were there. We were trying to find out what solution Utah can come to that works for us here. Because Utah, we want those options that work for us. And so that's what we want to help facilitate. So, yes, Utah Health Policy Project does want to expand Medicaid here in Utah, but we want to find an option that gets coverage to the 123 or 5,000 numbers or Utahns, 123,000 Utahns, and we want the federal match rate to be enhanced, the higher rate, and then we also just want to make sure that it's timely, because the longer we take to make this decision, the longer these individuals go without health insurance coverage.
All right, and there are options. We'll get into those options throughout the evening and discuss what's available to us. David, your thoughts? I know the Utah Hospital Association has put out a message that they support expansion with some conditions. What's your thinking?
Well, certainly this is a big decision for the state. The decision whether or not to expand Medicaid for the state, and I appreciate the legislature's thoughtful approach to how they've looked at this. Also, the governor's taken a very thoughtful approach, because it does have serious ramifications with the state, both if we decide to expand and if we don't. Certainly, within the Utah Hospital Association, we support that expansion, and within the hospital, we support that as well within the university health system. Medicaid is designed as really a partnership between the federal and state government to provide insurance to low-income individuals. And so in this state, that's an important decision that we need to make, and it does allow us to be able to provide coverage for those individuals that don't currently have it in our state. And so we do need to look at it very carefully and look at all of the ramifications that go along with that. But we have made the decision on both of those groups to support that.
Okay. Derek Monson with Sutherland Institute, a think tank here in the state, deals a lot with policy. Where are your thoughts when it comes to expansion of Medicaid?
Yeah, we're opposed to the expansion of Medicaid, and primarily it fundamentally comes down to one thing, which is that the expansion of Medicaid envisioned under Obamacare is really based, if I can just be frank, it's based on a lie. And it's based on the lie that the federal government is going to be able to provide all the funds in perpetuity, the 90% coverage in perpetuity that they say they are. If you look at, for example, the American Institute of CPAs, a bunch of people whose primary mission is to help us all remember that when it comes to our finances, 2 + 2 continues to equal 4. They're not a partisan group; they're a math group, basically. And they put out a study in 2011 that said, in that year, when things have probably gotten a little worse since then, that the current levels of debt and the social insurance obligations, Social Security and Medicare obligations of the federal government were already larger than the entire net worth of the country, of every citizen in America, the household net worth. So you think about that. That doesn't include anything in Medicaid at that point. We're just talking about those three things. And now they're coming in saying, but we'll still pay for 90% of Medicaid in perpetuity. But if they, again, if they shut down basically the country by taxing every ounce of net worth out of the country, they still wouldn't be able to pay for Social Security, Medicare, and the current amounts of debt. And I don't know how you can really believe then that they're going to be willing and able long term to pay for those, pay for the expansion like they say they will. And I don't think it's a good thing or even a responsible thing to promise these hardworking families, we're going to give you health care, only to then have to come back and either take it away because we don't want to raise taxes when the federal government takes funds away, or potentially harm their economic opportunities by raising taxes in ways that might take away their jobs, which is that's just as bad as losing their health care. So that's really, I think, what it comes down to.
David, what about this issue of the money issue? Because that's the biggest concern. I mean, the federal government right now is promising, 100% through 2017 and then 90% after that. But how comfortable can we be that that money is always going to be there for us?
Well, I think certainly that's a real issue. And, certainly the federal budget deficit is probably our biggest issue we're dealing with, aside from some of the things that we're talking about today. The money issue is very real. The reality is, though, that we're spending this money now. And that money is being spent by healthcare providers providing, again, coverage to individuals who do show up in the most expensive way in our emergency departments, not getting some of the proactive care that we see. And unfortunately, then that cost does get passed along to individuals. It's to some extent that hidden tax of what Medicaid and is, because that gets passed along to businesses in the form of higher premiums. And so the expense is out there. This is a way of simply bringing that expense back to, again, the tax dollars that we will already be paying out as part of this amendment. And the state of Utah will pay out $6.4 billion in those taxes. And the question is do we continue to let that money go out of the state, or do we take advantage of that and bring that back into the state to provide health insurance coverage? Now, again, I think, as we look at the ACA amendment as it is now, I don't think that we take that on carte blanche. I think we do have to make it a specific solution to Utah, and there's several models and examples out there that can make that unique and put more accountability back into the way that Medicaid is administered now, so that we can bring some of that cost piece and aspect back to the individual, which is not traditionally done in Medicaid. So it's very real. I think the cost is a very real question, but the cost is there now. It's just being borne in other ways.
Mm-hmm. Representative Dunnigan, your thoughts on the cost issue, because that appears to be the big issue that I think a lot of people are looking at right now.
I want to mention a couple of things. One is, of the 120,000 or so, whatever the number is that you mentioned, that would gain coverage under full Medicaid expansion. If we don't expand, about half of those would be eligible to get tax credits or subsidies through the new federal exchange or marketplace. So it's not like 123,000 or whatever the number is wouldn't have access to subsidized insurance. Half of those people would. If we don't do anything, there's a mandatory expansion which is going to increase by maybe 50,000 the number of people on Medicaid in Utah. That's going to happen no matter if we want it to or not, because the federal government has changed the rules. But of the 120,000 in addition to the under expansion, half of those would still be eligible for tax credits. The question is, do we need to expand Medicaid all the way up to 138% of poverty when people between 100% and 138%, which is half of the folks, can get heavily subsidized commercial products on the exchange? And there's some advantages to that.
Okay, any panelists, any other thoughts?
Yeah.
Riley, I see you ready to say something. Feel free to jump in anytime.
I mean, Dunnigan is right in that, half of those would qualify for subsidies, but you have to remember the other half as well. Utah Health Policy Project, we have an organization called Take Care Utah, and we have individuals coming into, these are Utahns, these are working families, these are working individuals, coming into our offices, applying for health insurance on the exchange, and getting told, sorry, we can't help you. You make too much to qualify for Medicaid and too little to qualify for tax credits on the subsidy. And these people are left in the dark because they cannot afford insurance without subsidies or without Medicaid on the regular marketplace. So
So there's got to be
There's
a
a gap.
solution.
Yeah, we
There
call
is
it
a
the
gap here.
coverage gap.
The
Yes.
coverage gap. All right. We've got a lot more questions to ask. We've got some calls coming in. We'll take those calls as well. This is our town hall meeting on the impact of the Affordable Care Act, and we're focusing tonight on Medicaid expansion. We'll take a brief break, 2-minute break, and we'll be back with more of our town hall meeting right here on Talk Radio 105.7 FM, 570 AM.
You're listening to a live town hall meeting on the impacts of Obamacare on the expansion of Medicaid in Utah, presented by Arches Health Plan, the way healthcare gets better.
All right, welcome back to our live town hall meeting on the Affordable Care Act and the impact that you have here in the state of Utah. And we're talking tonight about Medicaid expansion. Let me reintroduce our panelists again tonight here on Talk Radio 105.7 FM, 570 AM. State Representative Jim Dunnigan, David Entwistle, the CEO of the University of Utah Hospitals and Clinics, also with the Utah Hospital Association, Riley Curtis with Utah Health Policy, and Derek Monson, the senior policy analyst with the Utah-based Sutherland Institute. An issue I want to bring up, there are a lot of issues, and we've got some calls waiting. We'll get to your callers, or the calls here in just a minute. We ask them to stand by. One of the issues that has arisen as a result of the rollout of Obamacare is that we have about, I think the number of figures I've seen are about 1.6 million people have registered or tried to get the health care through Obamacare. But the issue is that a lot of those people, instead of going to the exchanges, are actually going to Medicaid and may in fact put an even bigger burden on Medicaid. If that is the case, how do we solve this problem? David, what are your thoughts on this if more and more people actually go to Medicaid instead of signing up for the exchanges and the insurance themselves?
I think that's certainly a challenge. One of the issues that we could talk a little bit about is what's called the crowd out impact, and that is those individuals or employers who are offering insurance now, will they take advantage of allowing their employees to go into Medicaid? Let me first of all say, Medicaid is not a program that attracts a lot of people that people are excited about. We at the hospital, there's individuals who are reluctant to sign up on Medicaid because sometimes that is viewed as an indigent program. And so it's not as though everybody's excited to sign up with Medicaid. But there is a concern is that if we offer this as a lower cost alternative, that businesses would take advantage of that. Now, I will tell you that, again, if as an employer, if you drop your health care coverage, it doesn't exactly show that you value your employees. At the same time, there is a penalty that the employer would have to pay as a result of that. So I do think as we think about, again, expansion within the state of Utah and how we go about that, then we also have to look at what are those protections against those individuals or employers that may choose to drop their own health care coverage in lieu of doing this, and look at some, I think, innovative ways to be able to put some preventions in about that.
Derek, how concerned are you? Those figures are out there that there are some people who are just going to Medicaid instead of signing up through the insurance exchanges. I mean, it puts a bigger burden on the program, does it not?
Yeah, it does, but and I think that does raise some questions about the viability long term if Medicaid is the primary, source or the primary destination that people are being driven to. But I think another thing that the Medicaid issue arises is I'll just share a story of a woman named Charlene in Washington State. I found out about this recently. A middle-aged woman, she went to the Washington State exchange to get a health plan, and she found that she qualified for Medicaid. She didn't want to be on Medicaid. In fact, she was willing to pay money to have a private insurance plan, but the exchange would not let her do anything but be on Medicaid at that point. Now, there's probably other ways, right? She could still sign up for insurance, but those exchanges are supposed to be the face of the program for a lot of people, and so it does raise issues when we're actually creating barriers to people in this case to do anything but be on Medicaid, and again, it kind of in microcosm represents some of the bigger fundamental flaws of the Obamacare law that is the overarching part of a Medicaid expansion.
Riley, your thoughts on this? Could the program, if more and more people opted to go Medicaid instead of the other direction, are you concerned in any way about Medicaid and taxpayers being able to pay for it?
I think what David had outlined with the crowd out, and I think that was a really good response, and we agree wholeheartedly with what he said. unfortunately, it is kind of at the point where, yes, if you go to healthcare.gov, they do screen you for Medicaid, and they don't push your application any further after that. And that is the case, but we feel that there are so many options out there to help pay for this expansion, and that's what we want to get to is, to the expansion and how can we afford it, and we want to come to solutions to how we can make it work in our state.
Riley and David, I pose this question to both of you first because David has written about this in an op-ed piece, and I know, Riley, you deal with people facing issues like this on an everyday basis. Put a human face on the need for Medicaid, if you would, and maybe share with us a story or someone who you think would tell the story and the need for this Medicaid in the state of Utah.
Yeah, the people that come to my mind are people who have their children on CHIP currently. And
what is CHIP for people
CHIP
may not know what that is?
Sorry, so CHIP is a program for children that we have here in Utah. It helps have them have health insurance coverage. It covers children from 0 to 133%, I believe. And their parents a lot of the time do not have health insurance. In order to be a parent, in order to receive Medicaid as a parent who has a child, you have to be at about, I think it's 50% federal poverty level. And that's no money. Like, that is nothing. And so these people have children and their children are covered, but how can you take care of your child if you don't have health coverage? If you get sick and you have to stay home from work, you don't take your child to school. I mean, there's just so many issues surrounding the family. And to me, the Medicaid expansion population are people who have families, and helping families, gain health care coverage and take care of the whole family instead of, yes, children are important, and Utah has so many children on Medicaid and CHIP, and I think that's wonderful, but what about the parents?
Okay. David, you wrote about that in your op-ed piece, the human aspect of Medicaid expansion.
Well, and I appreciate that you brought this up. I mean, this is a real example. We have people in our community that are working hard, that are making a living. They are able to, again, provide for their family. But again, through mechanisms that they can't either afford, or the place that they work doesn't provide that insurance. We have real examples of those individuals who unfortunately are involved in accidents, end up in the emergency department with medical conditions that they didn't expect, that actually end up in real need of the coverage that we provide. Certainly within the university health system and other healthcare providers within the state, there's literally hundreds of millions of dollars in care that's being provided to these individuals. Not that they're not working hard and trying their very best, but there is a real face to those individuals that end up in our facilities, of which there's a real cost as well. And we feel and have an impetus to care for them. And again, those costs do get passed along to others, but the care still needs to be provided.
Representative Dunnigan, you have mentioned before, is there a way that we can steer some of these people more to the private insurance sector instead of Medicaid or programs like that? Is there a way to do this?
I believe that there is, and I think we need to do it, and I'll try to go through this quickly. When we give people a Medicaid card and say, okay, you have access to care, they go to a doctor or hospital, they incur services. We do not reimburse the doctor or the hospital what the cost of that service is. We pay them Medicaid reimbursement rates, which are below the cost. So then those providers cost shift to those with commercial health plans, and the rates for everybody goes up. So one idea that we're looking at is what we call premium assistance, and we have these new Medicaid eligibles go and purchase products in the commercial sector from companies like Blue Cross, Select Health, Altius, et cetera, and we use the Medicaid dollars to pay their premium for them. Advantages to that: the providers get reimbursed at commercial reimbursement rates, so that we've stopped this cost shifting from the Medicaid patients to the others. But the advantage to the Medicaid enrollee is right now there are fewer and fewer doctors that are taking Medicaid because of the low reimbursement. If we pay those providers a commercial reimbursement and we give them access to commercial networks, those folks will have better access. So that's certainly one thing that we need to look at. Is it's called premium assistance. Some other states have initiated that and been approved recently from the Center for Medicare and Medicaid Services, and so Utah ought to look at that.
What is the reimbursement rate for doctors right now? Is it about 72 cents on the dollar? Do you know?
Well, certainly that varies quite a bit, and
Does
it
it
certainly
vary?
varies by payer, but that would probably be high.
That
72
way,
cents on
so
the
really,
dollar,
is that
yes.
low?
Yeah.
Will Medicaid expansion, David, you being in the hospital industry itself, if Medicaid expansion comes without what maybe Representative Dunnigan just mentioned, will we see more and more doctors refuse to take Medicaid patients? I mean, is that a real possibility?
I think that's certainly a possibility. Certainly, as we look within the university health system, this is part of what we provide. And so, again, we're looking for solutions to be able to continue to provide, again, care to those federal payers, both Medicare and Medicaid, because, again, both of those are challenging from that perspective. But I do want to come back to what Representative Dunnigan said. There are some real solution opportunities to use the Medicaid dollars in a unique way for the state of Utah. 2 states have now been approved, and in fact, Iowa's program just got approved yesterday. But it really puts some of that, the premium dollars, as Jim was talking about, puts it in such a way that we can, in certain categories of Medicaid, actually put those dollars somewhat at risk to those individuals and make them share as part of that payment, so that, again, the individuals who are in Medicaid within those categories can still have a real part of that. So again, it's not just something that's a free program to them. And some of the other states and waivers that we've seen, which is different than what we've seen as traditional Obamacare, these really are unique approaches that these states are trying to bring more accountability to the way the Medicaid is administered in their programs.
One of the issues, and we'll break here in a minute, I know, and we've got some calls, but one of the issues that I've read about, when it comes to care, you have doctors who don't take Medicaid patients, and Medicaid patients are, in fact, treated a little bit differently. It does take them a little bit longer to see the doctor. There are questions if they are getting the right care. In fact, the quality of care isn't as good. Is that a fair criticism, Riley or David, or anybody could speak to this here on the panel? Are they getting the quality of care, and are they having access to the care the way others would have if they're a Medicaid patient?
Well, certainly as a provider, I can speak to that, and I can tell you within the university health system, the way that we treat any payer, any patient that comes in the door is indifferent to their payer type. So again, we provide the care that's needed based on what they present with. And so again, there isn't delays based on the payer that you have. However, again, as you look at those elective items or those things that they, again, may want to have or may need to have, that's not based on some critical nature of which they present, those don't become available based on payer type. So again, there are some things, but again, in terms of the quality, the access, the way that that's presented, again, that's indifferent in regards to payer. However, not probably everyone within the provider community is in that same light.
Riley, have you heard anything about this from people you talk to who are Medicaid patients who say, we can't get in to see the doctor, or there aren't enough doctors available, or they're available but they're at such a distance I can't afford to get there?
Yeah, we have resources out there, and I wanted to point out that I was looking at Utah Department of Health numbers earlier today, and there were about 4,000 new providers in 2012 that signed up to accept Medicaid patients, and they also reinstated or recredentialed over 5,000 doctors as well. So it's not that, and I'm not 100% sure how many doctors would drop Medicaid patients, but I just want to show that the numbers are there, that people are still accepting Medicaid.
Okay, and they are doctors are available too.
Yeah, and there's sources for individuals to go to find out who can help them.
All right, we'll come back with some phone calls and your questions. Studio audience, if you have a question, we have a microphone here for you, as well as we continue with our town hall meeting on Medicaid expansion here in the state of Utah with Talk Radio 105.7 FM, 570 AM.
A live town hall meeting on the Affordable Care Act, Obamacare, and the debate over expanding Medicaid in Utah, presented by Fringe Benefit Analysts, simplifying the Affordable Care Act for you and your business.
All right, welcome back to our live town hall meeting here on Talk Radio 105.7 FM, 570 AM. If you have a question for our panelists, our phone lines are open tonight, 888-570-8010. As I mentioned, you could text us at 59570 or email us at rod@knrs.com. And let's get to one of those calls right now. We have Joey on the phone in Riverdale tonight. Joey, how are you? And welcome to our town hall meeting. Do you have a question for our panelist?
Yes, thank you for having me on. My question is, the fact is you have a lot of people out there that are just right now outside of the Medicaid area, and so for whatever reason, they don't go to the doctor until something drastic happens, and then when they do go, they go to the emergency room, and they can't afford to pay it because they're not making enough income. But our society ends up paying it anyhow. The bad thing about it is it gets in such a bad case that it ends up costing a lot more money, time, and effort to try to take care of the patient. What are we doing about those people? Or what will we do about those people?
All right. What do we do with people who don't qualify by the sounds of it, as Joey was saying, or have unusual circumstances? How do we help them out?
I think that's part of the challenge with what we're looking at with this expansion, because there are those individuals, as pointed out, that don't have coverage. Again, part of the safety net, and certainly as we look at what EMTALA provides and others, that's why the emergency rooms are there. Now, they're a very costly place, but they do provide that life-saving care, and certainly are there for those in times of need. The challenge is how do we provide that ongoing coverage to those individuals who will have ongoing issues sometimes as a result of these injuries. But again, this is where we think there is an opportunity with those that are falling outside of that within the federal poverty level with the expansion that will get that care that they need.
Derek, I know Sutherland, you've expressed opposition to Medicaid expansion. How do we help out people, in your opinion, who are caught in this trap?
Yeah, one of the things that we've suggested to policymakers and others that you look at is the many models of charitably provided health care out there that we have. There are dozens of clinics out there right now, and hospitals. We have Shriners Hospital as an example, that provide health care on a largely just charitable basis, or on a purely charitable basis in some cases. And they do wonders, and I know that's hard to really grasp until you go to one of these clinics and you see what they really do with what they really have, which is they do miracles with very little. And I think that there's a lot of possibilities there, and this is the proposal that we've encouraged, is to look at ways to tap into the charitable care market, if you want to call it that, sector of the healthcare market, to try to leverage it, to organize it, and to coordinate it better so that it can do more than it is doing, or to expand it even.
We've had calls into my show on that. Riley, is there enough charity care, charitable care out there to help these people, do you think, or is that not the answer?
Charitable care has played an integral part in our healthcare system that we currently have here, and it provides so much care. I mean, we couldn't be where we are without it. But I want to point out that, going to a charitable organization for a broken arm, yes, they can take care of you. Yes, they can put a cast on you. But what if you go for a mammogram and you find out that you have cancer? What can the charity care organization do for you at that point? And what about the comprehensive coverage, the continuation of care? Those are the questions that we have and wonder about, where does charity care stop working for our Utahns?
Okay. Representative Dunnigan, I know this has come up. Lawmakers, I've had some lawmakers suggest there's more that charity care or charitable care can do. Your thoughts on it? I mean, could it help out?
Certainly, charity care can help. I don't think it can solve and be the entire solution. I happen to agree with Riley that some of the basic care can be done with charity care. You get in some of the higher end or hard costs, either diagnostics or medical procedures, and you've got to assemble a lot of dollars together to cover those in charity care. Certainly a place and a piece for charity care, probably alongside some other initiatives.
What about charity care from a hospital point of view? David?
Well, I think certainly we're providing it now. I mean, if you look at certainly within the university health system, we provided over $100 million last year in uncompensated care. I think the reality is what happens to those individuals who do have real need of services. And I appreciate Riley's example with cancer. There's a real cost to that, and there's an ongoing cost. If you look at transplant, and we had real examples within our own organization, where if you look at the several $100,000 needed, in some cases, to do a solid organ transplant, there's also a very real cost each month for the anti-rejection drugs, thousands of dollars a month that go on for life. And so how do you, again, provide some of that care in a way that's sustainable over time without, again, burdening the other part of your health system to, and having to increase those costs to others that are paying. And so again, there's a lot of charity care that's being provided now, and again, I think that's part of the staple of our healthcare system, that we are providing that. But again, it's not a sustainable strategy as we look moving forward, and even what we would need to provide in terms of some of the procedures that perhaps aren't being done now that are on an elective basis.
We are taking your phone calls, 888-570-8010, or your text messages on this. Many of us don't go to the doctor until we absolutely have to. I think that's a general feeling among a lot of people. Will Medicaid in some way encourage people to take the steps at preventative care, to go early, to have those constant checkups? Does, in fact, that help that situation? What do you think, Representative Dunnigan? I mean, let's be honest. Most people don't go to the doctor until they absolutely have to.
Well, that's true, but that's, I think, largely true even with people who do have preventive care coverage right now. Sometimes we're afraid to go, afraid they might find something.
Mm-hmm.
So, but there was an Oregon study where they looked at people prior to when they got health care through Medicaid and then after, and what they found is that after they had it, their health status had not changed. They were not healthier. They did utilize health care services more. If you give somebody an insurance card, they'll use it more than somebody that doesn't have it. So certainly there's a place for preventive care, but it's not, in my opinion, it's not like if we cover preventive care, that's going to solve the problems. It's not. I mean, that's a tool, but it is not the solution.
Riley, let me ask you your opinion on that. I mean, if people have Medicaid, will they take those early steps to avoid a greater problem down the road?
Yeah, to Representative Dunnigan's point, referencing the Oregon study, it did show that people did utilize their care more. I remember there was statements about using like diabetic medication and everything like that, following the doctor's instructions more thoroughly. And that helps later down on the road. And then also it showed that it reduces medical bankruptcies. And so if you help the family, instead of the family wondering how they're going to survive, if they've got Medicaid coverage, if they've got insurance and health coverage, and then they don't have to worry about how they'll survive, they can worry about how they can thrive.
Okay. Now I want to move on to another area and talk about when it comes to Medicaid. In researching this and reading up as much as I can on a very complex issue, I heard two terms, the new eligibles and the old eligibles. The new eligibles, of course, are people who would sign up, from what I understand, and get the 100% or 90% paid for by the federal government. But then there's the issue of the old eligibles, people who are already eligible for it, and if they signed up, they would only be covered to the tune of about 57%. Representative Dunnigan, you're holding up a chart. Is that, in fact, the case, and would that be an additional burden on the states?
Okay, yes, and that's actually an excellent point. Just got the latest numbers on those who have enrolled in the Federal Healthcare Exchange or Marketplace. From October 1st, when it opened, or theoretically opened, through the end of November, there have been 1,800 Utahns who have applied for coverage for commercial products. There have been 8,000 Utahns who have applied and been determined that they're eligible for Medicaid. Now, largely those are people who we call the currently eligibles, or the woodwork effect. They're eligible now, they haven't signed up, but now with all the attention and the requirement that next year everybody have insurance, they're coming out. So we have 8,000 new Medicaid enrollees potentially in 2 months of currently, we haven't expanded, so those are currently eligible, and Utah is going to have to cover the cost of that at the current 70-30 match. The feds pay 70%, we pay 30%. So that's an additional expense that we have to cover. One little side note on that 8,000, and this is a problem with the Federal Healthcare Exchange, it's likely that some of those are not eligible for Medicaid, even though the exchange told them they were, because the federal government is assuming that we have expanded Medicaid on their criteria. Unfortunately, some of those folks have been told they're eligible for Medicaid, and they will find out that they are not.
Now, let me ask you, do we know what the cost of that will be for those 8,000 that you're, any idea at this point, or is it too early?
I don't know. Of course, the 8,000 is for 2 months now, and it will grow, and that's going to impact our budget next year and every year before we even get into any expansion at all. But I don't know. I don't know what the number will end up being.
David, your thoughts on that? I mean, that's a real issue. I mean, we're going to have to deal with that somehow.
Right. Well, and as I was alluding to earlier, obviously there's those individuals now who haven't signed up, and this is actually those individuals, the woodworking effect, so to speak, are those individuals that are coming out.
Is that the same as the old eligibles?
Yeah, the old eligibles, yes. Woodworking or old eligibles. I will say, though, and I give our own state credit because, again, we moved to a different model this last year as we look at the way that we pay insurance companies and those that provide health insurance under what's called a capitated or a fixed payment basis to be able to help, again, health insurance plans that offer Medicaid insurance for the state and administer that, to do that in a very cost-effective way. So what you were alluding to in terms of the health and wellness piece, we're actually more actively managing, we're reaching out as health plans and as providers to those patients to try to more actively help them, again, manage their own health. My thought, again, and as we're seeing some of the preliminary data, is that'll allow us, for those individuals who didn't sign up, who are getting into that we can manage those patients in a more cost-effective way. So looking at more long-term savings for the state. But certainly there is a cost, and as Jim alluded to, right now it's that 70-30 split. Certainly under the new plan, it would be 100% for the next 3 years and then a 90-10%, but it's still 90-10 of a larger amount as opposed to the 70-30 that we are providing now.
What about the concern, Derek, on the old eligibles or the woodworking effect, folks?
Yeah, no, and this is one that's actually quite personal for me because I have a younger sister who would be considered an old eligible. She's a young single mother, two children, two young boys, and so all this stuff impacts her, my nephews, my sister, in a very real way. And while I'm not all versed on all of the intricacies of what that means, I do think one issue it does raise is when you get into the unsustainability of the Medicaid expansion, because the federal government simply doesn't have the money to pay for it, regardless of what they tell us today, and the equity issues that then raises when we do have to fix that problem, if we expand or even if we don't expand. And there's a lot of, now you're having to go back and tell people we can't give you what we promised you, or what you've been getting is no longer going to be there. I'm just not sure that's the right way to go for the state.
Well, there are several options available to Utah, and I know efforts have been made to look at those options. When we come back in our final segment here, we'll talk about the options, what Utah could do differently, where we stand with the federal government, and the timetable on all of this. I think that's facing the state, and we've got to deal with the timetable as well, and we'll get to those issues coming up in our final segment of our live town hall meeting, the impact of the Affordable Act, if I can spit it out. And thank you, folks. I think I do work in radio, and we'll take your calls and comments. That's all coming up right here on Talk Radio 105.7 FM, 570 AM.
What does Obamacare mean to you? You're listening to a live town hall meeting about the Affordable Care Act on Talk Radio 105.7 FM, 570 AM.
And welcome back to our final segment of our town hall meeting on the Affordable Care Act and Medicaid expansion here in the state of Utah, and where we go. We promised we'd take some questions. We've got some people in the audience tonight who want to ask our panelists some questions. So, sir, give us your first name and go ahead with your question, if you would, please.
All right. Yeah, my name's Mark. I'm originally from St. George, Utah. I live up here now. Just a brief story as far as my personal experience with this type of thing. When I was in second grade, my dad went into the hospital with a pancreas problem. He was there for 3 months, and my family ended up, when it was all said and done, over a 22-year period, for that surgery, paid $1.8 million. My dad worked 2 jobs after that, and on top of that, his life insurance policy was what actually paid off that bill. Mm-hmm. He's a small business, worked for several jewelry stores down in St. George, and was unable to afford insurance at all. And I know that there would have been a massively different impact on my family. I mean, my parents were never home. The clothing that I got when you go to school at the end of the year, gym class throws its clothes out. That was my shopping spree. Mm-hmm. So I'm sitting here talking to a bunch of people wearing suits that honestly I don't think they get what they're doing. If there's a rising tide that Ronald Reagan talked about, I think that's what they're suffering the consequences from now, because that tide's not rising. You look at the top 1%, and they have more money than they'll ever know what to do with, and it's not getting distributed the right way. I honestly, if like you take this gentleman here from the Sutherland think tank. Ask him where he gets his money from. He doesn't get it from poor people. He gets it from rich people. They say that there used to be a race war. Now there's a class war.
Let me hold you up there.
No,
I just ask a question if you would. I appreciate your statement, and that's what you have. But ask a question if you would.
My question
'cause we're running out of
specifically for
time.
the medical thing is if we don't want to go to government, why do our medical expenses cost 2 to 3 times more than any other country? We pay through the nose for medicine in this country, and nobody's talking about that. If you want to reduce a lot of costs, how about you rein in some of those things? Where you're paying like $20,000 for like a chunk of metal that goes into a hip. Like that's too much. And you can go. There's insurance companies that are sending their patients to other countries to get their things fixed wherever it is, and they're paying them. These people to go there and vacation there to get that stuff done. That doesn't need to be happening, but it is happening because I do see that there is a class warfare. I see suits protecting their money. That's all I see.
All right. Well, let me ask David. Let me ask you this question: cost of healthcare, major issue. We take days delving into that, but is there a way to control the cost or bring the cost down?
Well, cost is certainly driven by utilization, and I appreciate your comments. Whenever you're faced with a bill, when you're in a traumatic situation, I was involved in an accident myself, and again, it was amazing how much that cost at the end of the day. The reality is we have a lot of different services that we provide. We have a high degree of healthcare coverage and a lot of technology, a lot of great treatments that go into that, but there is a real expense to that. And again, it's driven by utilization, it's driven by what you need, it's driven by I think what we're trying to, again, perceive as quality of care and some of the things that we offer. But there are some real disparities even across the country. I can tell you the state of Utah is, again, thoroughly recognized throughout the country as being one of the lowest cost providers in the state. So I think within our state we have a very low cost, but that doesn't mean that it doesn't have real impact on individuals that end up in our facilities.
Gentlemen, you sir have a question as well. Please go ahead. Thank you.
Frank.
Frank?
I'm wondering what we're going to do to curb the abuses of the system. I know from experience, as working as a healthcare consultant in many hospitals, that a lot of parents show up on a 24-hour basis via ambulance to bring their children in when they have a runny nose. And emergency departments are required to cover those, to admit those patients in the hospital. Why don't we have 24-hour primary care clinics in our facilities that could take care of those rather than turn that over to a very expensive emergency department system?
That's a great question, Frank. And I was talking with a couple of doctors the other day who brought that same issue up. How do we convince people stop going to the ER because it is expensive?
I guess I would ask the question, first of all, why are they going to the ER? Is there not other alternatives for them to see their primary care provider during the day? And again, there's a lot of different reasons.
Well, the parents work or whatever, and so they're not available to come until after hours when a primary care clinic closes. They're 8 to 5, 9 to 5 operations, and so they have a child that gets sick with a runny nose. So I've seen it at Texas Children's Hospital, where the ambulance arrives with a mother and a child, and the nurse is, my gosh, he's only got a runny nose, but she's on Medicare, or she's got a CHIP program or whatever.
Well, again, and I think, there's alternatives that certainly, and I can tell you within the University Health System, of extended hours, again, urgent care clinics that are less cost alternative to the emergency room, even nurse call systems and other things that make that available. But there's got to be a better education about where and when is the appropriate use of the emergency room, and sometimes it's okay to wait until you can see your primary care provider the next day. And in some cases, again, with Medicaid expansion, though, sometimes the ER is used because they simply don't have access to providers because they don't have health insurance. And so in those cases, there's a real opportunity to save on the cost of how people are utilizing it, because this is the only avenue in some cases they have is to utilize the emergency room.
We're about to run out of time, but before we do, I know Representative Dunnigan, the legislature, has given the governor some options. In about a minute and a half time, can you explain what those options are? I know that's a challenge, but they maybe pare this down to the options that you've recommended that the governor consider.
Okay, in a minute and a half. I love your sense of humor. So one option is don't do anything, don't expand. We'd still cover 50,000 more Utahns under mandatory expansion. Option number 2 is do a partial expansion from 0 to 100, expand Medicaid to take care of those folks. Then we're done, because 100 and above, they can go to the exchanges and get good subsidies. Option 3 that we passed was expand Medicaid from 0 to 138%, but use premium assistance to allow people to have commercial policies, greater access to providers, and pay providers commercial reimbursement rates.
The middle option that you suggested. I understand some other states have already received that. Am I correct in that, or somewhere
they've
along that
received
line?
a variation on the last or the third option. Nobody has received approval for that middle option. That makes the most sense, but under that scenario, the federal government would pay more, states would pay less, and federal government's trying to shift all the costs to the states that they can.
And we are considering options, right, Riley? I mean, those are options that is your group saying we'll take a look at them.
Oh, most definitely. We were so excited after that last hearing to hear that 2 out of the 3 options were moving forward in some sense.
Okay. David, where does the Hospital Association stand on this?
Certainly, as we see this, those are viable options. Certainly, we don't agree with the one not to expand, the first representation there.
Us too.
Again, the 100% scenario, again, as Jim pointed out, has not been approved yet. And again, that would be a real challenge within the state. But certainly the premium solution, or what we're calling a more specific Utah solution, becomes much more viable from our alternative.
Music is our cue. Panelists, thank you very, very much for being here tonight. Our audience, thank you. We hope you've been able to learn something. For our sponsors, our great engineering staff, thank you in this live town hall meeting. Again, thank you very much, and we'll be back with the Rod Arquette
You've
Show
been
starting
listening to a live
at 4.
town hall meeting on the Affordable Care Act and if Medicaid should be expanded in Utah. The town hall meeting has been presented by Fringe Benefit Analysts, simplifying the Affordable Care Act for you and your business, and by Arches Health Plan, the way healthcare gets better. This has been a special presentation of Talk Radio 105.7 FM, 570 AM.